Assalamualaikum and good day to everyone. My name is Solihin, Pharmacist from Hospital Teluk Intan. For my presentation, I would like to share on Vancomycin latest update, in which I will touch on Vancomycin changes from Trough to area under the curve monitoring. A little introduction on Vancomycin. As we all know, Vancomycin is a glycopeptide antibiotic which has broad spectrum gram-positive coverage, and it is mainly used in MRSA infection. Major concern when using Vancomycin is nephrotoxicity. This usually happens when given high dose in order to target trough level of 15 to 20. Nephrotoxicity also can occur when Vancomycin is being used concurrently with other nephrotoxic drugs, such as aminoglycoside, for example. What we have been practicing back then, according to Vancomycin 2009 guidelines, only trough level is needed for Vancomycin monitoring. Trough level of 10 to 15 is targeted for uncomplicated infection. Higher trough level, which is 15 to 20, is targeted for severe infection. Now, the new Vancomycin 2020 guideline recommends switching trough-only monitoring to monitoring of area under the curve to minimum inhibitory concentration ratio. Generally, each antibiotic has its own pharmacodynamic parameter that predicts their effectiveness. Some concentration-dependent antibiotic like aminoglycoside and fluoroquinolone, we want to target higher peak. Time-dependent antibiotic, for example, beta-lactam antibiotic, we want to keep concentration above MIC for as long as we can. However, Vancomycin on the other hand doesn't really quite fit either of these, and it's more to AUC above MIC dependent, meaning that we are looking at overall Vancomycin exposure. We are targeting AUC above MIC of 400 to 600, and this is for over 24 hours period. There are few assumptions made with AUC over MIC monitoring in this new guideline. The first one, this is specifically being used for Staph aureus, so it doesn't really apply to other type of bacteria. The second is that the guideline assuming the MIC of Staph species is 1 to Vancomycin. In most cases, it can be true. However, there can be cases where the MIC value is higher, which is 2, indicating Vancomycin could be resistant, so it becomes a bit difficult to achieve adequate AUC over MIC ratio. In this case, we may consider switching to alternative antibiotic like linezolid if patient is not responding to Vancomycin. There are two methods for AUC monitoring, but I will focus on peak and trough concentration only because this is what we practice in the hospital. The reason why we need this peak and trough concentration is to estimate area under the curve. Generally, target range of AUC 24 hours in most indication is 400 to 600. There are some cases where the target range of AUC 24 hours is 600 to 800, for example, if MIC value of 2, or higher Vancomycin dose is needed to penetrate blood-brain barrier in CNS infection. However, bear in mind that we don't want to push AUC too high because it will increase the risk of acute kidney injury. Okay, for the blood sampling, it should be taken at steady state. Post-dose sampling 1 hour after infusion end and pre-dose 30 minutes before next dose. We can take sampling within dosing interval, or what we usually practice is around 1 dose, since we don't have to wait so long between the level. This AUC monitoring will be done in patients with normal renal function only because the main purpose is to prevent Vancomycin-induced AKI. There are few challenges to implement these changes. Therapeutic drug monitoring is a multidisciplinary approach that involves healthcare staff, from blood taking procedure by the nurse or doctor, next pathology team that interpret culture and sensitivity and also TDM analysis, then pharmacists that interpret the result, dose calculation and give recommendation, and lastly physician who treat the patient. Okay, one of the challenges will be blood sampling. Back then, we used to take pre-dose sample only. But now, pre and post-dose sample are needed. And please take note that post-dose sampling to be taken at least 1 hour after infusion end to make sure the drug in the blood and in the tissue are in equilibrium. And not to mention also to write sampling time correctly in the form. From pharmacy side, we totally depend on the information given. Therefore, if there is some wrong information, it will lead to incorrect AUC estimation. Our limitation is to determine exact AUC value. The most relevant method to calculate AUC is by using trapezoidal calculation. So we can use lockdown method. Okay, this method tends to overestimate AUC value since we have to extrapolate the curve. And linear up lockdown method. This method tends to underestimate because there are some areas are not covered. Next, there is limitation in susceptibility testing method, in which lack of precision and variability in MIC result depending on method used. Based on CLSI, broth microdilution is a gold standard method. There are alternative methods such as BD-Finite, VITEC2, microscan e-test. Unfortunately, depending what method hospital is using, you can get differences in result. In other words, for example, using same specimen, if some hospital done gold standard MIC by broth microdilution and get value of 1, other hospital using BD-Finite might get value of 0.5 because Finite tend to undercall the MIC value. On the other hand, another hospital using e-test, they might get value of 1.5 or 2 because e-test tend to overcall the MIC value. So this will be challenges for physician trying to decide what to do with MIC of 2. Is it really 2 or is it actually just 1? Therefore, it is important to make decision not only based on susceptibility result MIC, but also taking consideration the patient as the whole, whether the patient having clinical response or not. Perhaps MIC of 2 is actually 1. On the other hand, if some patient who has MIC of 2 but is not responding to standard therapy, perhaps that is the situation that we might want to consider alternative option. Lastly, the biggest challenge is shifting to new practice. Previously, we are too familiar with monitoring Trough only as part of routine culture. Even the 2009 guideline itself mentioned peak monitoring no longer necessary. And now, 11 years later, peak and Trough are needed for AUC estimation. So now we have to relearn and adapt to peak Trough concentration again. And I guess this is part of nature in medicine. What was old become new again, and we have to adapt with the changes. So in summary, practice will be changing from Trough only monitoring to peak and Trough monitoring for Vancomycin. This will allow for area under the curve estimation for better prediction of Vancomycin efficacy and safety profile. Lower Trough value of 10 to 15 actually tend to produce enough AUC. Targeting higher Trough value of 15 to 20 in normal renal patient that we have been practicing in recent years, it will probably exposing patients with high dose Vancomycin and predisposing them to acute kidney injury as the result. That's all from me. If you guys have any question, just email to me and I will try my best to answer the question. Thank you for your attention.